Imagine you're an emergency room physician. It's like 2 in the morning.
Always the best time for complex cases.
Right, exactly. The department is just completely overflowing, and the paramedics just wheeled in an older gentleman.
Okay, setting the theme.
Yeah. So he's profoundly confused. He doesn't know what year it is. His speech is super slurred, and he's highly agitated.
That's a classic terrifying ER presentation.
It really is. So now you have this massive diagnostic dilemma on your hands. I mean, is he having a stroke?
Could be.
Does he have, like, a raging brain infection? Is it a psychiatric break? Or is one of his major internal organs just quietly shutting down?
Right, and you have to figure it out fast.
Exactly. You've ordered a stat CT scan of his head. You've ordered a full panel of blood work. But, the scanner's backed up.
It always is.
Always. And the lab needs at least an hour to process those vials. But you don't have an hour. You need a clue right now.
And this is where the sheer elegance of the physical examination comes into play. I mean, you don't need $1 million imaging machine or a complex biochemical assay to make your next move here.
Which is amazing.
It really is. You
Right.
just step up to the bedside, you look the patient in the eye, and you ask them to perform one incredibly specific, surprisingly simple physical maneuver.
Just holding their hands up.
Yeah, exactly, as if they're stopping traffic. And within 30 seconds, the way their hands move, or rather, the way their hands completely fail to maintain that position,
Right.
can instantly tell you if their brain is physically damaged from a stroke or if it is just drowning in systemic toxins from, say, a failing liver or kidney.
That is just incredible. So for you listening, today we are mastering a single clinical sign that acts as a real-time window into the neurometabolic state of the human body.
We're doing a deep dive into Asterixis.
Yeah, Asterixis.
Yeah.
And for this deep dive, we are structuring our analysis exactly like an exclusive ward round at a teaching
I
hospital.
love this format.
Me too. We're going to walk you through the exact steps of the physical exam, the deep pathophysiology of why the body betrays itself this way, and how clinicians use this visual clue to solve some really complex medical mysteries.
It's basically the ultimate form of clinical detective work. And, to truly appreciate Asterixis, we have to look back to its origins in the medical literature.
Let's do it. Where did it start?
Well, it was first comprehensively described back in 1953 by two brilliant neurologists, Raymond Adams and Joseph Foley. They were working out of Boston.
1953 is such a fascinating era in medicine because, we just take for granted today that we can just slide a patient into an MRI tube and see the exact architecture of their thalamus.
Oh, absolutely. Or draw a millimeter of blood and know their precise ammonia levels in a few minutes.
Right. But Adams and Foley didn't have that luxury. They were relying entirely on their hands, their eyes, their reflex hammers, and just their profound understanding of neuroanatomy.
Exactly. And our sources detail how they were studying patients who were descending into what was then called hepatic coma. Hepatic meaning liver.
Right. Liver failure. They were observing patients with severe cirrhosis and other liver pathologies who were developing these progressive neurological deficits.
And they noticed something specific.
They did. Adams and Foley documented this really specific movement disorder that appeared as these patients deteriorated. They described it as an inability to maintain a sustained posture.
So not just general weakness.
No, not at all. It was a highly specific arrhythmic lapse in motor control. And for decades, because it was so frequently observed in these liver patients, the medical community just colloquially referred to it as the liver flap.
The liver flap, I've heard that term, but as we'll see today, that name is actually a bit of a historical misnomer, isn't it?
It really is.
Because while the liver is a major player, it is far from the only organ capable of triggering this sign. So let's get right into the practical application.
Let's do it.
Let's take that patient we introduced in our hook. Let's call him patient A. The older gentleman, confused, waiting on labs in the ER.
Okay, patient A, you're at the bedside. Walk us through the exact step-by-step physical examination required to uncover Asterixis. Because I know it's not just having them arbitrarily stick their arms out.
No, precision is absolutely vital here. The primary method requires you to ask patient A to hold his arms straight out in front of him, fully extended at the elbows, parallel to the floor.
So arms straight out like a zombie from a classic horror movie.
Correct. But the arms alone aren't enough. The crucial detail, the part that actually tests the specific neurological pathways we are targeting, that happens at the wrist.
The wrists, okay.
Yeah. The hands must be strongly dorsiflexed. You instruct the patient to bend their hands backward at the wrist as far as possible with their fingers spread.
Like a traffic cop.
Exactly as if they're a traffic cop signaling a car to stop.
Okay, so arms extended, wrists cocked all the way back, palms facing forward. That requires, like, a lot of active muscle tension in the forearms, doesn't it?
It does. It engages the extensor carpi radialis longus, the brachius, and the extensor carpi ulnaris.
The extensor muscles.
Right. You are forcing the brain to send a massive continuous wave of electrical signals down the spinal cord, out through the radial nerve, and into those forearm extensors, just to hold that position against gravity.
And against the natural resting tension of the flexor muscles on the other side of the arm.
Exactly. It's an active, high-demand state.
And here is the detail from the text that really caught my attention. The time factor.
Yes, this is where people mess up.
Right. You don't just ask them to do this and immediately let them drop their arms. The clinician has to make the patient hold this highly specific, tense position for at least 30 seconds.
Sometimes even up to a minute.
Why 30 seconds, though? I mean, if the brain is compromised, why doesn't the system just fail immediately?
It's a phenomenal question, and the answer lies in the concept of neurological reserve and synaptic fatigue.
Synaptic fatigue. Okay, break that down.
Well, we are testing the sustained motor tone pathways. When you initially assume a posture, your cortex sends a burst of command signals. Even a metabolically compromised brain can usually muster the energy for a short, forceful burst of action. But maintaining that posture...
That's the hard part.
Exactly. That requires a complex, uninterrupted, continuous feedback loop involving the motor cortex, the basal ganglia, the thalamus, and the cerebellum.
So it's essentially an endurance test for the central nervous system.
Precisely. By forcing patient A to hold the dorsiflexed position, you are deliberately placing a sustained load on that continuous neurological signal.
You're waiting for it to break.
You're waiting for the compromised system to fatigue. In a metabolically toxic environment, the neurons simply cannot maintain that rapid, continuous firing rate indefinitely.
Wow.
After 10, 20, or 30 seconds, the neurotransmitter reserves just deplete faster than they can be replenished. Or the toxic interference disrupts the synapse, and the signal momentarily drops.
So you really have to wait for the crack in the foundation to show under that sustained pressure.
You do. If you check for 5 seconds and walk away, you'll miss it entirely.
Okay, but let's be practical for a second. Patient A is an older guy. He's confused. He might be lethargic or physically frail.
Sure.
What if he just cannot physically hold his heavy arms out in front of him for half a minute? Do we just abandon the test?
Absolutely not. The literature provides a very clear, equally effective alternative method for patients who are too weak or somnolent.
Oh, good. What is it?
Instead of having them hold their arms out in space, you have them rest their arms flat on the bed, prone, meaning palms down against the mattress.
Okay, arms flat.
Then you simply ask them to bend their hands backward, dorsiflexing the wrists so the hands lift off the mattress, while their forearms remain fully supported by the bed.
I see. So the shoulder and bicep muscles get to rest, but the wrist extensors are still under that severe sustained load.
Exactly. The mechanical principle is identical. You are isolating and stressing the extensor pathway. And again, you wait the full 30 seconds, watching the hands intently.
Let's visualize this happening. We're at the bedside. Patient A has his arms out, wrists cocked back. We are 10 seconds in. His hands are trembling slightly, maybe just from the effort. 20 seconds. We are staring at his fingers. And then, right around the 30-second mark, we see the reveal.
The flap.
Yes. Patient A's hands suddenly flap downwards. And it's not a rhythmic waving motion.
Yeah, not at all.
It's a sudden, arrhythmic dropping of the hands forward, followed almost immediately by a brief, highly distinct upward jerk back to the original dorsiflex position.
Drop, catch, drop, catch.
Exactly.
That is Asterixis. When you see that sudden drop and active recovery, the entire clinical picture crystallizes. You have just identified a major systemic derangement without looking at a single lab result.
Let's deconstruct the physiology of that flap, because honestly, it is incredibly counterintuitive.
It trips a lot of people up.
Right, because if someone without medical training looks at that movement, they almost always describe it as a muscle spasm. They think the patient's muscles are twitching or convulsing.
But our sources are emphatic on this point. Asterixis is emphatically not a muscle spasm.
So what is it?
It is the physiological opposite of a spasm. A spasm or a cramp is an active, involuntary contraction of a muscle.
Like a Charlie horse.
Right. It is a sudden surge of electrical activity forcing the muscle fibers to shorten. What you are witnessing with Asterixis is a precipitous, momentary loss of muscle tone.
A loss of tone, the electrical signal just vanishes.
Exactly. If you were to hook patient A's forearm up to an EMG machine that measures the electrical activity in the muscle, you would see a dense, thick band of constant electrical noise while he holds his hands up.
That's the brain screaming, holes, hold, hold.
Right. But the moment the flap occurs, the EMG goes completely flat.
Wow, flat lines.
It is a period of absolute electrical silence that can last anywhere from 50 to 200 milliseconds.
The brain just literally stops talking to the muscle.
For a fraction of a second, the descending motor pathways completely fail. The extensor muscles in the forearm go totally flaccid.
And without that active tension, gravity instantly takes over and the hand drops forward.
Gravity does the work of the flap. Yes.
And then the brain catches the error.
Yes. The proprioceptive sensors in the wrist and tendons fire an emergency signal back up the spinal cord saying, hey, we lost position.
We're going down.
Exactly. The brain receives this, reboots the signal, and fires a massive active command to yank the hand back up into dorsiflexion.
So that upward movement is active recovery.
Yes. The downward flap is passive falling.
I love thinking about it through an analogy. I was visualizing this earlier. It's not like a car engine suddenly surging and jolting the vehicle forward, because that'd be a spasm.
Right.
Asterix is like a massive passenger airplane flying along at 30,000 feet. The engines are humming, maintaining altitude. That's the sustained posture.
Okay, I like this.
And suddenly the airplane loses all engine power for a split second. The plane naturally drops out of the sky. Then a second later, the engines violently catch again, and the pilot yanks the yoke back to pull the plane back up to altitude.
That is a brilliant way to visualize it. The flap is the moment the engines cut out. The recovery is the engines catching again.
So Asterixis is fundamentally an interruption in the continuous signal required to maintain posture against gravity.
Exactly.
So we've established what is physically happening. The electrical engines are cutting out. Now we have to ask the critical diagnostic question, why are they cutting out?
The clinical reasoning step.
Right. We touched on the history of the liver flap, so let's start there. If patient A has liver failure, what is actually happening in his bloodstream that is causing his brain to short circuit?
This brings us to the core of metabolic encephalopathy. The liver is the body's primary filtration and detoxification plant.
The chemical factory.
Right. One of its most vital jobs is managing nitrogenous waste, specifically ammonia. Every time you digest protein, or even just through normal cellular metabolism and the bacteria in your gut, ammonia is produced.
And ammonia is bad news.
Ammonia is highly toxic. A healthy liver scoops up that ammonia, runs it through a complex biochemical assembly line called the urea cycle, and converts it into urea.
Which is safe.
Yes, urea is water-soluble and safely excreted by the kidneys in your urine.
But if the liver is cirrhotic or failing acutely, that factory shuts down.
The ammonia has nowhere to go. It begins to accumulate in the bloodstream, leading to a state of hyperammonemia. And here is the critical vulnerability. Ammonia is highly lipophilic.
Meaning it loves fat, which means
It easily crosses the blood-brain barrier,
it just slips right past the brain's security system.
right into the cerebral tissue. Once inside the brain, the local maintenance cells, the astrocytes, try to neutralize it.
They're trying to clean up the mess.
Exactly. They combine the toxic ammonia with glutamate to form a benign molecule called glutamine. But when there is a massive flood of ammonia, this defense mechanism goes into overdrive.
Oh, I see where this is going.
The astrocytes swell up with all this excess glutamine, causing low-grade cerebral edema.
Brain swelling.
Yes, so the physical architecture of the brain is actually swelling. And furthermore, because the astrocytes are using up all the local glutamate to neutralize the ammonia, they deplete the brain's primary excitatory neurotransmitter.
Because glutamate is the gas pedal for the nervous system.
Exactly. At the same time, ammonia increases the tone of the GABA system, which is the brain's primary inhibitory neurotransmitter, the brake pedal.
So you have no gas, and the brakes are jammed on.
Precisely. The synaptic environment becomes overwhelmingly inhibitory and metabolically exhausted.
So when you ask patient A to fire that continuous high-energy signal down to his wrists for 30 seconds,
The glutamine-swollen astrocytes and the disrupted neurotransmitters simply cannot support the energy demand. The signal drops out, the engines stall.
that is incredible. The liver fails in the abdomen. and within hours, the neurotransmitter balance in the motor cortex collapses.
The body is entirely interconnected.
But our deep dive sources tell us we absolutely cannot stop at the liver. If we just assume Asterixis equals liver failure, we are going to misdiagnose a lot of patients, right? We have to cast a wider metabolic net.
We absolutely do. While hepatic encephalopathy is the classic association, uremic encephalopathy is an equally potent trigger.
Uremic encephalopathy. So we're talking about the kidneys now.
Yes. End-stage renal disease or acute kidney injury. We just discussed how the liver turns toxic ammonia into urea. Well, the kidneys are responsible for actually filtering that urea.
Along with a host of other metabolic waste products.
Right, pulling it out of the blood and into the urine. When the kidneys fail, the urea builds up in the blood, a condition called uremia.
And just like ammonia, I'm assuming urea and these other uremic toxins cross the blood-brain barrier.
They do. The exact pathophysiological cascade of uremia is slightly different from ammonia.
How so?
Well, it involves an imbalance of parathyroid hormone, calcium disruptions in the neurons, and the accumulation of specific uremic neurotoxins like guanidino compounds.
Guanidino compounds, okay.
But the macroscopic result is identical. The brain's metabolic environment becomes toxic, synaptic transmission becomes erratic, and the sustained motor pathways fail under load.
So the same clinical sign from a different organ failing.
Exactly. In fact, our literature notes that uremic encephalopathy is almost always associated with Asterixis. It is a highly reliable sign for kidney failure.
Okay, so we have the liver, we have the kidneys. What about the lungs? Can respiratory failure really cause this specific motor deficit?
It absolutely can. We are talking about hypercapnic encephalopathy.
Hypercapnic, so high carbon dioxide.
Yes. If the lungs fail to ventilate properly, perhaps due to severe COPD, emphysema, or an acute asthma exacerbation, they cannot blow off carbon dioxide. CO2 rapidly builds up in the bloodstream.
And high CO2 makes the blood acidic, right?
It drops the blood pH, but it also has a profound direct physiological effect on the brain. High levels of CO2 are a potent vasodilator in the central nervous system.
Meaning it opens up the blood vessels.
It causes the blood vessels in the brain to swell open, increasing intracranial pressure. This combination of increased pressure, local acidosis, and secondary hypoxia profoundly disrupts neuronal firing.
It's a perfect storm for the brain.
It is. The texts note that while slightly less common than the liver or kidney presentations, severe hypercapnia is a well-documented cause of Asterixis.
Okay, let's synthesize this. If we visualize the clinical reasoning pathway here, let's mentally whiteboard a process diagram. We can start to see a universal structural rule emerging.
Walk me through it.
Think of the metabolic process as a massive cascade. So, step one, at the top you have an organ failure. The liver, the kidneys, or the lungs.
Right.
Step two, the failure causes systemic toxins to accumulate in the bloodstream.
Step 3.
Because it's in the blood, it circulates equally everywhere. The entire brain is bathed in these toxins simultaneously. Therefore, the failure of the motor pathways happens on both sides of the brain. The result is bilateral Asterixis. Both hands flap.
That is the defining diagnostic rule of metabolic encephalopathy. Systemic causes produce bilateral signs.
But this brings us to the absolute pivot point of our award round. The most critical diagnostic distinction we are going to cover today. The bilateral versus unilateral rule.
This is where clinical reasoning gets really sharp.
Because our sources make it very clear that Asterixis does not always happen in both hands.
The clinical fork in the road. If the cause is metabolic, or as we will discuss later, a systemic medication effect, it is always bilateral.
Okay.
However, if the cause is a localized structural lesion in the brain, meaning a stroke syndrome, an infarction where tissue dies from lack of blood flow, or a hemorrhage where a vessel bursts and bleeds into the brain tissue.
A physical brain injury.
Right. The vast majority of those cases manifest as unilateral Asterixis. Only one hand flaps.
Wait, stop the presses. Let me make sure I'm completely locking in this clinical reasoning because this is huge.
Go for it.
If I am in the ER with patient A, and he holds his arms out, and only his left hand drops and catches, while his right hand remains perfectly steady.
Yes.
I instantly stop thinking about his liver and kidneys.
You immediately pivot your diagnostic hypothesis.
I stop worrying about a blood draw for ammonia, and I start screaming for an emergency CT scan of his head, because unilateral Asterixis means there is localized physical damage.
Precisely. You shift from a systemic metabolic paradigm to a focal structural paradigm. The guidelines state clearly that unilateral Asterixis must be presumed to be secondary to an infarction or hemorrhage until proven otherwise.
Now, you said the vast majority. I know medicine hates the word always.
Yeah.
Can a stroke ever cause bilateral asterixis?
It is extremely rare, but technically possible. If a patient suffers a massive bilateral stroke or a stroke in a very specific midline structure that perfectly impacts both descending motor tracts simultaneously, you could theoretically see a bilateral flap from a structural cause.
But that's a zebra, not a horse.
Exactly. From a clinical reasoning standpoint, at the bedside, unilateral means stroke and bilateral means metabolic or toxic.
Okay, let's test this knowledge with a new scenario. Welcome to the ward round, patient B.
Okay, patient B, let's hear it.
Patient B is a 55-year-old woman. She is brought in with sudden onset right-sided weakness. We run the rapid point-of-care labs. Her liver enzymes are pristine. Her kidney function is perfect. Her blood oxygen and CO2 are totally normal.
So we're ruling out the major metabolic players.
Right, but we do the 30-second sustained dorsiflexion test, and she exhibits a profound, undeniable asterixis in only her right hand. Her left hand is a rock.
A classic presentation of unilateral asterixis.
So, based on our rules, we are hunting for a structural lesion. We are hunting for a stroke. Let's do a line diagram in our heads for this structural pathway. Vascular issue leads to infarction, which leads to focal signal disruption, which leads to unilateral asterixis.
Perfect line diagram.
But the brain is a massive, complex network. Where exactly do we look? If we push her into the MRI scanner, where are we expecting to find the dead tissue or the bleeding?
This requires a deep dive into functional neuroanatomy. The continuous motor signal required to hold those hands up isn't just a simple wire running from the cortex to the wrist.
Right, it's not just a straight shot.
It's a complex circuit involving multiple way stations. And when we see unilateral asterixis, our sources provide a highly specific localization map of where that circuit is most commonly broken.
Let's name the suspects. Who is the most common culprit for unilateral asterixis?
The single most commonly implicated structure by a wide margin is the thalamus.
The thalamus. Now, for any of you listening whose neuroanatomy is a bit rusty, the thalamus is a pair of egg-shaped masses of gray matter situated deep in the very center of the brain, right above the brainstem.
Yes.
I always conceptualize the thalamus as the grand central station of the brain. It's the ultimate relay hub. Almost every sensory signal coming up from your body and a massive portion of the motor signals trying to coordinate movement have to stop at the thalamus to be routed to the correct part of the cerebral cortex.
That is an excellent visualization. Specifically for motor control, we are looking at the ventrolateral and ventroanterior nuclei of the thalamus, the VL and VA nuclei.
Okay, the VL and VA, what do they do?
These nuclei receive input from the cerebellum and the basal ganglia, process it, and project it up to the primary motor cortex. They are vital for coordinating and sustaining complex postures.
So if a blood clot lodges in the small arteries, feeding the thalamus, causing a focal stroke, that relay station just goes offline.
Exactly.
The continuous signal from the cortex tries to get through, but the bridge is out.
The signal drops, the engine's cut out, and you get the flap. But the thalamus, while the most common, is not the only suspect.
Where else on the circuit can a break cause this?
Well, the structural lesion could be higher up in the cerebral cortex itself. Specifically the frontal cortex, which houses the primary motor strip and the supplementary motor areas responsible for initiating voluntary movement.
Okay, the frontal cortex.
And occasionally, lesions in the parietal cortex, which handles sensory integration and spatial awareness, can also disrupt the feedback loop enough to cause asterixis.
So from the cortex down to the thalamus, where does the circuit go next?
It involves the basal ganglia, the deep brain structures that smooth out and regulate motor commands. A stroke there can cause the flap.
Makes it.
We also look at the cerebellum, the cauliflower-shaped structure at the back of the brain, responsible for balance and fine motor coordination. And finally, the lesion could be located further down in the brainstem itself, in the mesencephalon, the pons, or even as low as the medulla oblongata, where the spinal cord begins.
Wow. That spans essentially the entire vertical axis of the central nervous system, from the very top of the cortex all the way down to the stem.
That's a huge circuit.
But here's the next piece of clinical reasoning I want to parse out.
Yeah.
If patient B has the flap in her right hand, where is the stroke located? Is it in the right half of her brain or the left half?
This introduces a fundamental law of neurology, the contralateral rule.
The contralateral rule.
Yes. The major motor pathways in the brain, specifically the corticospinal tract, originate in one hemisphere, travel down through the brain, and then physically cross over to the other side of the spinal cord in an area of the lower medulla called the pyramidal decussation.
So the wires cross.
Because the wires cross, the left side of your brain controls the right side of your body, and vice versa.
So if the descending motor signal originates in the left brain but crosses over to control the right hand, a structural lesion causing unilateral asterixis is generally contralateral, meaning on the opposite side to the affected hand.
Exactly. For patient B who is exhibiting a right hand flap, your immediate presumption should be that she has suffered a stroke in the left hemisphere of her brain, most likely a left thalamic infarction.
A left-sided stroke causes a right-sided flap.
Yeah.
It's wonderfully logical. But, I have spent enough time digging through these medical texts to know that neurology loves a curveball.
Oh, it really does.
Is the contralateral rule 100% foolproof? Are there exceptions where the flap happens on the same side as the brain damage?
You are right to be suspicious, and you found the exact caveat in the literature. There are critical exceptions. If the stroke occurs in specific lower structures, the rule flips.
It flips.
The text explicitly points out that lesions in the cerebellum, the pons, and the medulla can cause ipsilateral asterixis, meaning the flap is on the same side as the brain damage.
Why does it flip? Why would a stroke in the right cerebellum cause a right-handed flap?
It has to do with the incredibly complex routing of the cerebellar pathways. The main output tract from the cerebellum, the dendroprothalamic tract, exits the cerebellum, crosses over to the opposite side to reach the contralateral thalamus and cortex.
Okay.
But then the motor signal from that cortex crosses back over in the medulla to go down the spinal cord. It's a double crossing system.
A double crossing system.
Yes. Because it crosses twice, the net effect is that a cerebellar lesion produces symptoms on the same side of the body.
Okay, so if I am summarizing patient B for the attending physician on our imaginary ward round, she has isolated right-sided unilateral asterixis. We strongly suspect a left-sided thalamic frontal or basal ganglia stroke, and we are ordering an MRI to confirm.
Good.
However, if the MRI shows the upper brain is clear, we must look closely at the right cerebellum and brainstem for an ipsilateral lesion.
That is flawless clinical synthesis. You have perfectly integrated the physical bedside sign with the underlying neuroanatomical wiring.
Let's complicate things even further. Let's move into an etiology deep dive that, frankly, blew my mind when I was reviewing the source material.
Let's hear it.
We've established that metabolic organ failure causes a bilateral flap. We've established that physical strokes cause a unilateral flap.
Correct.
But what if we have a patient who has completely healthy organs? Their liver and kidneys are pristine, and they have a perfectly clean MRI with absolutely no evidence of a stroke, yet they are sitting there with a profound bilateral asterixis. What invisible force are we missing?
This scenario demands that you review the patient's medication list immediately. We are entering the realm of iatrogenic causes.
Iatrogenic. Remind me what that means again?
Iatrogenic literally means illness caused by medical examination or treatment. We are talking about pharmacological side effects.
So the drugs we prescribe are short-circuiting the system.
Precisely. The medical literature lists a highly specific set of medications capable of inducing bilateral asterixis, even in the absence of any underlying organ disease.
Who are the most frequent offenders on this list? If I'm looking at the chart, what drugs should make alarms go off in my head?
The most frequent offenders belong to a class called antiepileptic drugs, or AEDs. This includes widely prescribed medications like gabapentin, pregabalin, phenytoin, carbamazepine, and valproate.
Okay, AEDs.
Another extremely common offender is lithium, which is the gold standard mood stabilizer used for bipolar disorder.
Okay, let's unpack the irony here. Antiepileptic drugs are specifically designed to stabilize brain electricity. They are prescribed to calm down hyperactive neurons and prevent seizures.
Yes, that's their job.
Yet these exact same drugs can cause this specific electrical dropout, this loss of sustained motor tone. How does a drug meant to prevent electrical chaos cause an electrical stall?
It's a fascinating pharmacological paradox. Take phenytoin, for example. It
Right.
works by blocking voltage-gated sodium channels, essentially slowing down the rate at which neurons can fire.
Which is great for stopping a high-frequency seizure.
Right. But as we discussed earlier, maintaining that 30-second posture requires the motor neurons to fire rapidly and continuously. If you over-inhibit those sodium channels, the neurons simply can't sustain the firing rate required for posture.
Oh, wow.
They fatigue prematurely, the signal drops, and you get asterixis.
So they basically overbreak the system, the drug works too well, and the sustained motor pathways become collateral damage.
Exactly. The same principle applies to lithium. Lithium alters a vast array of intracellular signaling pathways and neurotransmitter releases. When lithium levels creep too high, it creates a toxic neurochemical environment that disrupts the basal ganglia and cerebellar loops, leading directly to the flap.
Our sources also mention a few uncommon offenders, just to be comprehensive. They list clozapine, which is a powerful atypical antipsychotic, levodopa, the primary treatment for Parkinson's disease, trimethoprim sulfamethoxazole, a common antibiotic combination, and aphosphide, an older chemotherapy agent.
And the text notes one highly specific, historically interesting special case, mitrizamide myelography.
Mitrizamide, what was that?
Mitrizamide was a contrast dye used decades ago. Doctors would inject it directly into the spinal canal to take X-rays of the spinal cord. The literature notes that as the dye migrated up into the brain fluid, it could trigger acute delirium accompanied by profound asterixis.
Wow, just from the dye.
Yeah, it was a direct, localized toxic effect on the brain tissue. We don't use it anymore, but it proves how sensitive the motor pathways are to chemical disruption.
But I want to zero in on one specific drug from the antiepileptic list, valproate, or valproic acid. Because as I was reading the source text, I found an incredibly fascinating nuance. It's a clinical loophole that really tests a doctor's physiological understanding.
Ah, the valproate loophole. It is perhaps the most brilliant example of secondary cascade effects in modern pharmacology.
Right, so let's say a patient is taking valproic acid for a seizure disorder. They come into the clinic, they hold their hands out, and they start flapping bilaterally. The immediate reflective thought for any clinician would be, it's a direct medication side effect, just like phenytoin.
The valproate is over-inhibiting the sodium channels and short-circuiting the brain.
Right, we just need to lower the dose. But the text says that might be completely wrong.
It might not be the valproic acid per se that is causing the motor pathways to fail.
Let's trace this cascade because it is beautiful in its complexity. Let's do another mental flowchart here.
I'm ready.
Step 1, valproic acid use. But the valproic acid doesn't attack the motor cortex directly in this scenario. Instead, it attacks the liver. Specifically, valproic acid interferes with the synthesis of carnitine, and it directly inhibits an enzyme called carbamoyl phosphate synthetase I.
And for anyone who remembers their biochemistry, that enzyme is the crucial first step of the urea cycle in the liver.
Exactly. So the drug chemically jams the urea cycle. Because the urea cycle is jammed, the liver cannot process ammonia. So step 2 of our flowchart, hyperammonemia. Massive levels of ammonia build up in the blood.
And we already know what ammonia does.
It crosses the blood-brain barrier, swallows the astrocytes, and causes. Step 3, secondary encephalopathy. And the encephalopathy causes, step 4, the Asterixis.
The clinical takeaway here is absolutely profound. The drug didn't cause the flap by altering brain electricity. The drug caused a localized metabolic failure in the liver, which poisoned the blood, which poisoned the brain, which caused the flap.
Why does understanding that exact chain of events matter so much?
Right.
I mean, why can't a doctor just say, drug bad, cause flap?
Because it completely dictates how you manage the patient and save their life. If you assume it's just a direct, benign side effect of the drug on the neurons, you might just slowly taper the dose and send them home to wait it out.
Right.
But if you understand the cascade, you realize you have a systemic, life-threatening metabolic crisis on your hands.
They have toxic ammonia levels.
Yes. You must immediately draw blood to check their ammonia levels. You have to stop the drug entirely right now. You might need to administer L-carnitine to restart the urea cycle, or lactulose to draw the ammonia out of their gut.
So you have to treat the blood, not just the brain.
Exactly. If you miss that distinction, the patient could rapidly progress from a flapping tremor into a deep hepatic coma and die.
That is the essence of why we do these deep dives. The brain is always listening to the blood. You have to look past the visible symptom to find the invisible cause.
It's the core of internal medicine.
Okay, moving forward, we need to talk about differential diagnosis.
Right.
We've spent a lot of time establishing what Asterixis is, but the ER is a chaotic place. Things look like other things. Involuntary movements can be notoriously difficult to categorize by eye.
They really can.
How do we tell the imposters apart? How does a doctor know for absolute certain they are looking at Asterixis and not something else entirely?
In neurology, distinguishing between different phenomenologies of involuntary movement is the foundation of diagnosis. The text specifically highlights two primary clinical mimics that you must definitively differentiate from Asterixis at the bedside:
And those are?
myoclonus and tremor.
Let's tackle myoclonus first. I hear that term thrown around a lot. What is it?
Myoclonus is a sudden, brief, shock-like involuntary movement caused by muscular contractions. And clinically, it is distinguished by one fundamental mechanical difference. Myoclonus is an abrupt gain of muscle tone.
Ah, It is the exact physiological opposite of our airplane losing its engines.
Precisely. Asterixis is a precipitous loss of tone. It is a failure of transmission. Gravity pulls the hand down.
Right, passive fall.
Myoclonus is an active, explosive burst of aberrant electrical activity from the cortex or brainstem that forces the muscle to contract violently. It results in a forceful jerk upward against gravity.
Let me offer an analogy to lock this in. Myoclonus is like touching a doorknob in the winter and getting a static electric shock that makes your whole arm jump.
Yes.
It's a sudden external zap of extra energy that forces your muscles to contract instantly. Asterixis, on the other hand, is like sitting in a boring 3-hour lecture fighting sleep.
We've all been there.
Right. You're holding your posture, and suddenly you lose the battle, your neck muscles go slack, your head drops forward, and then you violently snap awake and pull your head back up.
That is a phenomenal, highly relatable analogy. The static shock versus nodding off. One is an explosive addition of electrical signal. The other is a sudden, momentary absence of signal.
So if you ask a patient to hold their hands dorsiflexed, and you see the hands forcefully jerk backward or upward,
You are dealing with myoclonus. And myoclonus has a completely different differential diagnosis, often pointing to specific anoxic brain injuries, severe drug toxicities, or different types of epilepsy.
so active jerk up equals myoclonus.
Yeah.
Passive drop down equals asterixis. What about tremor? Millions of people have tremors. People with Parkinson's disease, people with essential tremor, or even someone who just drank 4 cups of espresso.
True.
A tremor makes the hand shake. How is asterixis different from a severe tremor?
Tremor is fundamentally different in its underlying mechanics and its visual presentation. A tremor is defined as a rhythmic, oscillatory movement around a fixed joint. And
Oscillatory.
it's caused by the alternating synchronous contraction of agonist and antagonist muscles.
So the muscles that pull the wrist up and the muscles that pull the wrist down are engaged in a tug of war.
Exactly. The flexors pull, then the extensors pull, then the flexors pull again. It creates a continuous, measurable frequency, an oscillation.
Like a metronome ticking back and forth. Tick-tock, tick-tock.
Yes, there is a distinct rhythm. Asterixis, however, is completely arrhythmic.
No rhythm at all.
There is no pattern, no steady beat, no predictable frequency. You might see a flap after 10 seconds, then nothing for 15 seconds, then 3 quick flaps in a row.
Wow.
Furthermore, its mechanism is entirely one-sided. It is not an alternating tug of war. It is simply the sudden drop from the extensors failing and the subsequent active recovery. It doesn't oscillate around the joint. It falls and is caught.
Drop and catch. Pause. Drop, drop, catch. Not a rhythmic shake. Okay, I feel incredibly confident I could spot the difference at the bedside now. So my final, ultimate clinical question for you, our expert educator.
I'm ready.
We've run the exam.
Hmm.
We've diagnosed unilateral or bilateral asterixis. We've ruled out myoclonus and tremor. What is the specific treatment for the flap? Do we give them a medication to tighten their muscles? Do we splint their wrists?
This brings us to perhaps the most important clinical and philosophical lesson of the entire deep dive. There is absolutely no symptomatic treatment required or even available for asterixis itself.
We do absolutely nothing to treat the flapping hands.
Never. The flapping hands are merely the smoke alarm. You don't put out a house fire by taking the batteries out of the smoke detector.
Great point.
The treatment paradigm is entirely 100% directed at identifying and reversing the underlying condition.
So let's run through the scenarios. If the patient has bilateral asterixis due to uremic encephalopathy from kidney failure, you treat the flap by
urgently consulting nephrology and dialyzing the patient. You connect them to a dialysis machine, manually filter the urea and toxins out of their blood, and as the brain's biochemical environment normalizes, the synaptic fatigue resolves, and the asterixis will naturally disappear.
if they have unilateral asterixis because of a left thalamic stroke.
You activate the acute stroke protocol. You manage their cerebral perfusion pressure, perhaps administer thrombolytic clot-busting drugs if they are within the critical time window, and ultimately rely on neurorehabilitation to help the brain rewire around the damaged relay station.
And if it's the valproic acid loophole we discussed, causing hyperammonemia.
You immediately halt the valproic acid. You administer agents like lactulose to trap the ammonia in the intestines and excrete it, and perhaps give L-carnitine to rescue the liver's urea cycle.
Fix the blood, fix the brain.
Exactly. The moment the ammonia is cleared from the blood, the astrocytes in the brain deflate, glutamate levels normalize, the continuous motor signal is restored, and the asterixis vanishes completely.
That brings everything full circle so beautifully. Asterixis isn't the disease, it's the messenger. It is the body frantically waving a red flag, begging the doctor to look deeper.
It is the perfect embodiment of internal medicine.
Well, we are reaching the end of our ward round today. The labs have come back on patient A, the MRI is done on patient B, and it is time for our final rapid revision, self-test, and closing thought. For you listening, it's time to consolidate everything we've learned. Let's do a lightning round review of the core concepts for your mental exam prep.
I will set the parameters. First, the history. Asterixis was first comprehensively described in the context of hepatic coma by neurologists Adams and Foley in 1953, earning it the early moniker of the liver flap.
Second, the clinical test. Arms extended straight out, hands maximally dorsiflex bent backward like stopping traffic, fingers spread. And crucially, you must make them hold it for at least 30 seconds to induce synaptic fatigue in the sustained motor pathways.
Third, the pathophysiology. It is emphatically not a muscle spasm. It is a precipitous momentary loss of muscle tone, an electrical dropout followed by an active recovery, the airplane momentarily losing its engines.
Fourth, the differential diagnosis. Remember the imposters. Myoclonus is an abrupt gain of tone, an active jerk upward like a static shock. Tremor is a rhythmic oscillatory tug-of-war around a joint. Asterixis is an arrhythmic, passive drop and active catch.
Excellent. Now, it is time for the self-test. We are going to ask you 4 clinical reasoning questions directly based on the mechanisms we've discussed today. We will pause briefly after each one to let you formulate the answer in your head before we reveal it.
Question 1. If you observe Asterixis at the bedside, and it is strictly unilateral present in only one hand, what broad category of etiology must you immediately presume is causing it? Take a second.
Got your answer?
The answer is a focal structural lesion in the brain, most specifically an infarction or intracerebral hemorrhage, a stroke syndrome, rather than a systemic metabolic failure.
Question 2. Following up on that, in cases of true unilateral asterixis, what is the single most commonly implicated deep brain structure where that stroke or lesion has occurred? Think about the relay station. The answer is the thalamus, the grand central relay station of the motor circuit.
Question 3. We did a deep dive into iatrogenic causes. What specific metabolic cascade does the anti-seizure medication valproic acid trigger, leading to secondary encephalopathy in Asterixis? Think about the flowchart.
Remember the loophole.
The answer is it inhibits the urea cycle in the liver, leading to hyperammonemia, toxic levels of ammonia building up in the blood and swelling the astrocytes in the brain.
And question 4, the final physiological question. At its cellular core is the downward flap of Asterixis caused by an abrupt active gain of muscle tone or an abrupt passive loss of muscle tone.
Thin or passive loss.
The answer is an abrupt precipitous loss of muscle tone resulting in electrical silence in the extensor muscles.
If you got all 4 of those right, congratulations, you passed the ward round with flying colors. But before we sign off today, I want to leave you with a lingering, almost philosophical thought to mull over.
Okay, what is it?
We spend so much time in medicine breaking the body down into separate disciplines. We have hepatologists for the liver, nephrologists for the kidneys, neurologists for the brain. We treat them as isolated silos.
It's a very compartmentalized view of humanity. Yeah.
But think about what Asterixis actually represents. Just standing there, holding your hands up, it seems so rudimentary. It's a simple posture, something we take for granted every single day when we hold a steering wheel or type on a keyboard. We don't dedicate a single conscious thought to it.
Right.
But maintaining that posture requires such an incredibly complex, vulnerable, and continuous symphony of electrical signals firing from the cortex, bouncing through the thalamus, and racing down the spinal cord.
It's a massive, energetic undertaking.
It's so delicate, so metabolically demanding that a completely unrelated organ failing a foot away in your abdomen, like your liver shutting down, can alter the pH of your blood just enough to cause that massive neurological signal to momentarily blink out of existence.
It is a profoundly fragile system, balanced on a biochemical knife's edge.
It is. It shows us that in the human body, the silos are an illusion. Everything is intimately connected. The brain is always constantly listening to the blood, and when the blood turns toxic, the body's posture collapses.
It's incredible.
It really changes how you look at the simple act of just raising your hand, doesn't it? It is a medical miracle every time we do it successfully. Keep asking questions, keep looking for the hidden connections, and we'll see you on the next deep dive.